And we're going to be focusing on side bending and rotation. I'm going to start us off with a seated position, because actually what you have to appreciate is it gets you into a really good habit biomechanically. Yeah? If you start looking at how we move around the table. Okay. So just talk to me very briefly. Now, we want to try and improve the quality and quantity of movement. Ultimately, this is why we're doing these techniques, okay? Cool. So ultimately, we want to look at trying to reduce the pain and improve the movement. So what goes wrong in this area? Talk to me. So patient comes in, why would I want to mobilise this area? Why would I want to work on the thoracic spine? What goes wrong? Pardon? Breathing. Okay, yeah, absolutely. So breathing mechanics, yeah? If we're going to think about respiration, we're going to think, all right, thoracic spine, and where do the ribs attach onto?
Spinal process.
No, they attach onto the transverse process. They're a demifacet onto the transverse process. It's a convex demifacet. The movements are slightly different, because the rib, we're looking more of a rotatory movement because of the facets. Yeah? Whereas the thoracics, what position are the facets in for the thoracic spine?
Downward.
Okay, they face outwards and backwards. Outwards and backwards, which means when we mobilise the thoracics, we tend to either do posterior to anterior, anterior to posterior. Okay, and the reason why is because we have the rib cage locking everything in. Rotation is pretty good. Rotation, maybe even a little bit of side bending can be very beneficial, but predominantly it's a sort of an AP, and we tend to normally get our patients to do extension work. Not massive flexion, it tends to be more extension type stuff, which can be very, very effective. So, if there is a respiratory compromisation, we'll cover that when we get into the ribs, more around the mechanism. If the ribs aren't moving properly, then there will be a compensation on the thoracic spine. Yeah, absolutely. Okay. So moving the thoracics will have a positive effect on the rib mechanics. Great. Cool. Also as a side effort, respiratory, if they're not moving nicely here, what does the body do? Compensates. Yeah. We get hypertonicity of the accessory muscles. So all of these muscles and movements here become hypertonic and tight. And actually, what's the first rib can be affected quite often. How's the first rib held? The first rib is held either up or down. Yeah. How is it dysfunctional? It gets the first rib gets held up. That's it. Yeah. It gets held up through the hypertonicity of the muscular structures, and in order to drop the first rib down by either mobilising the C-spine or CT, the thoracics, we can have an effect on reducing the muscle tone. So we affect the muscular reflexogenic element and drop the first rib down. Yeah, you can manipulate the first rib as well, but that's not always appropriate. Which it's a little more tricky. But we will cover it actually. I'll show you how we can manipulate the first rib. So mobilisation of the thoracic spine is really important. In fact, when someone has back pain, what happens to this area? Yeah, exactly. Why does this area become tight and stiff if they have pain here?
Decrease mobility.
Yeah. Because the body's compensating, isn't it? It goes, oh shit, I don't want to move my lumbers, so now it starts to fucking move massively from the T-spine. Then this becomes slightly dysfunctional, and then we end up getting issues CT. Actually, to be fair, I'm a big fan of thoracic mobilisation. The thread